Surgical board case review, rapid-fire clinical vignettes. Let's get right into it. A 15-year-old male on conservative management for an appendiceal mass develops a rising pulse rate, a spiking high-grade fever, and worsening localized pain. An urgent ultrasound confirms the mass has actually suppurated into an appendiceal abscess. So what is the most appropriate management strategy here? Is it A, image-guided percutaneous drainage of the abscess in continuation of antibiotics, B, urgent open laparotomy with immediate appendectomy, C, image-guided drainage followed by immediate interval appendectomy in 3 weeks, D, maintain the conservative Shahan protocol, or E, perform an emergency right hemicolectomy?
The correct choice is image-guided percutaneous drainage. When an appendiceal mass suppurates, the absolute primary treatment of choice is image-guided drainage paired with targeted IV antibiotics. What's really fascinating here is the concept of the decompressing shield. Basically, percutaneous drainage controls that acute septic focus, which completely avoids the heavy morbidity of an emergency laparotomy in a highly inflamed right iliac fossa. Now, if the collection tracks deep down in the pelvis, it can actually be safely drained transrectally or via a posterior colpotomy. Then, once the sepsis is fully resolved, a formal interval appendectomy is scheduled for 3 months later.
A 37-year-old male presents with migratory periumbilical pain shifting over to the right iliac fossa. He has a temperature of 103 degrees Fahrenheit, a pulse of 105, and you palpate a distinct tender mass. What is the most likely diagnosis? A, acute right-sided ureteric colic, B, obstructing advanced carcinoma of the cecum, C, acute uncomplicated appendicitis, D, acute right-sided pyelonephritis, or E, appendiceal abscess.
The diagnosis is an appendiceal abscess. The crucial takeaway here is combining that classic migratory pain of appendicitis with a high-grade fever and a newly palpable mass, which clearly tells us the appendix has perforated and effectively walled itself off. Remember, uncomplicated appendicitis characteristically presents with just a low-grade fever and definitely lacks a discrete mass. This scenario perfectly illustrates the Shahan protocol for conservative management. A key pearl for the wards, you literally must mark the boundaries of that mass right on the patient's skin using a pen so you can carefully monitor for any expansion over time. A 55-year-old male presents with a 10-day history of right lower quadrant pain. He's hemodynamically stable and a firm, well-localized, tender mass is palpated on exam. Crucially, there are no signs of generalized peritonitis. What's the most appropriate initial management strategy? A, initiate conservative medical management. B, emergency open appendectomy. C, urgent emergency laparoscopic appendectomy. D, emergency lower midline exploratory laparotomy, or E, prophylactic subhepatic closed suction drain. If you went with conservative medical management, specifically the Shahan regimen, you nailed it. When a stable patient presents late, meaning over 5 days, with a stable localized mass, our non-operative strategy relies strictly on NPO status, IV fluid resuscitation, and broad-spectrum antibiotics. But you have to know your failure triggers. You absolutely must abort this trial and proceed straight to urgent laparotomy if the patient's vitals deteriorate, or if that pain and fever spike. We want to avoid surgery during this acute phase if at all possible, because dissecting through a dense appendiceal mass carries a massively high risk of iatrogenic cecal injury and a nightmare postoperative fecal fistula. A 55-year-old male complains of persistent dizziness, anorexia, and significant weight loss over 2 months. He has 0 altered bowel habits. However, he is severely anemic with a hemoglobin of just 6 grams per deciliter, and a firm, irregular, non-mobile right iliac fossa mass is palpated. What is the most likely diagnosis? A, obstructing ileocecal hemoboma. B, abdominal actomycosis mass. C, uncomplicated acute appendiceal mass. D, primary cecal carcinoma. Or E, hyperplastic ileocecal tuberculosis.
The answer is primary cecal carcinoma. Think about it. An older adult presenting with severe cachexia, a hard irregular mass, and profound iron deficiency anemia is highly indicative of a right-sided colon cancer that's undergoing silent chronic ulceration, all without showing early obstructive signs. Distinguishing this from the other differentials is key. An appendiceal mass would give you a classic acute history of migratory pain. Ileocecal tuberculosis typically affects much younger adults presenting with strictures, and an amoeboma presents with a clear history of blood-stained dysentery. Following a complete splenectomy for high-grade trauma, which cellular change on a peripheral blood film serves as the most reliable pathognomonic marker confirming an asplenic or hyposplenic state? A, widespread presence of nucleated spherocytes. B, presence of Howell-Jolly bodies. C. Abundant collections of cytorocytes, D. Flat, thin, marginated target cells, or E. Severe, sustained chronic thrombocytopenia.
The most reliable marker is the presence of Howell-Jolly bodies. The underlying mechanism here is truly fascinating. Howell-Jolly bodies are smooth, round little DNA fragments left inside red blood cells. Normally, the spleen's reticuloendothelial macrophages just pit them right out. But after a splenectomy, the complete loss of this pitting mechanism makes these persisting bodies a pathognomonic marker. You'll also see other peripheral stigmata like target cells and cytorocytes. Keep in mind, platelet counts will rise sharply after removing the spleen since it acts as a storage reservoir, and this post-op thrombocytosis definitely increases long-term thromboembolic risks for the patient.
A postoperative patient is being closely monitored following an open splenectomy for a hematological disorder. Which of the following conditions represents a recognized, incredibly common respiratory complication that drives early postoperative morbidity? A. Catastrophic generalized systemic coagulopathy. B. Acute onset idiopathic thrombocytopenia. C. High-altitude acute respiratory distress syndrome. D. Left-sided reactive pleural effusion, or E. Continuous refractory paralytic ileus. The correct answer is a left-sided reactive pleural effusion. Pulmonary complications are actually the absolute most common cause of early postoperative morbidity in these cases. The surgical dissection directly beneath the left hemidiaphragm leads to local irritation, splinting, atelectasis, and ultimately a reactive effusion. Looking at our broader complication matrix, you also really need to watch out for subphrenic hematomas, overwhelming post-splenectomy sepsis, and iatrogenic injuries to the fragile tail of the pancreas during hilar cross-clamping. A 60-year-old male is undergoing regular post-operative surveillance following a curative surgical resection for an oncological colorectal tumor. What is the most effective, cost-efficient screening investigation for early recurrence? A. Scheduled screening colonoscopy every 3 months. B. Non-contrast CT scan of the pelvis. C. Routine serial qualitative fecal occult blood testing. D. Longitudinal tracking of serum CEA levels. Or E. High-resolution pelvic MRI. The absolute best approach is the longitudinal tracking of serum CEA levels. The absolutely crucial point to remember is that a progressive, linear rise in carcinoembryonic antigen is highly sensitive and will often precede any clinical or radiological detection by several months. Standard surveillance protocols mandate checking CEA every 3 to 6 months for the first 3 years post-resection, alongside your annual contrast-enhanced CT scans. Remember, while CEA is your go-to systemic marker, high-resolution pelvic MRI is the specific modality of choice to delineate local, extraluminal recurrence. A 40-year-old male is undergoing an elective exploratory laparotomy for a hepatic flexure adenocarcinoma. A solitary 3-centimeter metastatic lesion is found on the free edge of the right liver lobe with 0 extrahepatic disease. What is the most appropriate intraoperative action? A. Proceed with right hemicolectomy alone. B. Right hemicolectomy combined with postoperative radiation to the liver. C. Synchronous right hemicolectomy combined with localized wedge resection of the liver metastasis. D. Close the incision and refer for chemotherapy. Or E. Construct a protective diverting loop ileostomy. The ideal action here is a synchronous right hemicolectomy combined with a localized wedge resection of the liver metastasis. Performing this single-stage resection of both the primary tumor and a solitary, completely resectable metastasis offers a massive 5-year survival advantage of up to 40%. This brilliantly illustrates a very unique oncological paradigm for colorectal cancer. Resecting isolated liver or lung metastases yields excellent outcomes. We literally only switch to a staged hepatectomy or ablation if deep bilobar metastases are encountered. A 50-year-old patient with chronic calcifying pancreatitis presents with severe, intractable pain. Imaging shows an 8-millimeter dilated main pancreatic duct absolutely packed with calcified stones. What is the surgical procedure of choice for durable pain relief? A. Radical distal pancreatectomy. B. Side-to-side lateral pancreaticojejunostomy. C. Endoscopic retrograde sphincterotomy. D. Pancreaticoduodenectomy, or E. Duodenum-preserving pancreatic head resection. The procedure of choice is a side-to-side lateral pancreatojejunostomy, better known as the Puesto procedure. For severe intractable pain and a duct dilated to 6 millimeters or larger, the Puesto procedure decompresses the entire system, providing incredibly durable relief in up to 85% of cases.
The technique requires opening the main duct longitudinally right along its interior surface and anastomosing it side to side to a ruined jejunum loop of the jejunum. Extensive trials absolutely confirm this surgery is vastly superior to repeat endoscopic stenting for long-term, durable relief. A 65-year-old male is admitted with an acute abdomen from a perforated appendix, complicated by generalized purulent peritonitis. Which structural or procedural parameter is correct regarding his management? A. Incidence peaks between 20 and 35 years of age. B. Localized right iliac fossa incision is preferred. C. Lower midline exploratory laparotomy is preferred. D. Primary closure of the skin carries a very low rate of infection. Or E. Antimicrobial coverage should be limited to 2 days postoperatively. The correct choice is a lower midline exploratory laparotomy. In older adult patients presenting with advanced generalized peritonitis, this specific midline approach ensures optimal visualization to perform thorough multi-quadrant lavage and to evaluate mimicking pathologies, like a perforated cecal carcinoma. The absolutely crucial wound management axiom to remember here is to securely close the abdominal fascia, but specifically leave the skin and subcutaneous layers completely open to heal by secondary intention. Post-op, these patients will require a full 5 to 7 day therapeutic course of systemic broad-spectrum IV antibiotics and metronidazole. A 34-year-old male is a chronic, completely asymptomatic carrier of Salmonella typhi. According to standard guidelines, what is the optimal first-line medical antimicrobial treatment to eradicate this chronic carrier state? A. High-dose oral chloramphenicol for 7 days. B. Multi-dose oral cotrimoxazole for 14 days. C. High-dose fluoroquinolones for 4 weeks. D. Extended-spectrum third-generation cephalosporins for 7 days. Or E. Immediate surgical cholecystectomy without prior drug trials. The optimal first-line treatment is high-dose fluoroquinolones, administered for a full 4 weeks. The core reason this is the first-line choice is that fluoroquinolones achieve phenomenal tissue penetration within the biliary system and gallbladder mucosa, which are the exact primary reservoirs for chronic colonization. S. typhi can literally survive within macrophages and colonize the biliary tree long-term. If a prolonged 4-week trial fails to eradicate the carrier state, the patient absolutely must then be evaluated for an elective cholecystectomy. A 36-year-old female is a chronic Salmonella typhi carrier with a multi-drug-resistant strain. She has already failed multiple prolonged courses of high-dose fluoroquinolones and cephalosporins. What is the definitive treatment to finally eradicate her carrier state? A. Switch to high-dose oral chloramphenicol for 6 weeks. B. Initiate long-term oral cotrimoxazole. C. Combine dual-agent fluoroquinolones for 3 months. D. Schedule an elective surgical cholecystectomy. Or E. Perform a radical total proctocolectomy. The definitive treatment is an elective surgical cholecystectomy. When a carrier state is completely resistant to prolonged antimicrobial drug regimens, definitive treatment requires physically removing the gallbladder mucosa and bile matrix. This structural niche relies on biofilms and gallstones as a primary reservoir, and excising it successfully eradicates the carrier state in over 90% of drug-resistant cases. Always remember this final pearl. Perform a preoperative ultrasound for cholelithiasis because the presence of gallstones drastically reduces the probability of successful antibiotic eradication, making a cholecystectomy absolutely necessary.